Have you ever written something like worked on memory tasks or addressed attention strategies and immediately thought, oh, this sounds so vague? Like, this doesn't reflect what I actually did in the treatment session. You're not alone. Cognition is one of the hardest areas to document, especially if you don't work in a neuro or cognitive rehab setting. But here's the truth. If you're a PT, OT, or assistant working in geriatrics, a SNF, outpatient, home health, even acute care, you're already working on cognition. You're probably just not documenting it in a way that makes it obvious. So, I'm Stephanie, I'm a PT, and together with Nicole, who's an OT, we're the founders of the Note Ninjas, and we help PTs, OTs, SLPs, and the students document in a way that reflects our clinical skill without spending hours second-guessing what you wrote. And today, I want to show you exactly how to document cognitive interventions clearly, confidently, and in a way that supports medical necessity, even if you're not in a neuro setting. Let's start with this. What even counts as a cognitive intervention? Because when I say the word cognition, most people immediately think of things like memory games, brain teasers, word searches, or doing paper pencil worksheets with someone who had a stroke. But that's not what most of us are doing day to day. And that's not what we're talking about here. Cognition shows up in way more subtle ways and more functional ways. So here's some common signs you're addressing cognition already, even without realizing it. Your patient forgets to lock their brakes before transitioning. They start brushing their teeth and then stop halfway through. They're confused about what day it is and can't follow a home exercise program. They forget safety strategies from session to session. They're unable to initiate a task without prompting. Those are all cognitive impairments, and they're absolutely appropriate to address in therapy. But here's the kicker. You can't just write worked on memory or provided safety education and expect it to hold up in an audit. We need to show what the functional challenge was, what specific strategy or technique was used, what level of support or cueing we provided, and what the outcome or carryover was. So, let me walk you through a few examples. Let's say your patient forgot to lock their brakes before transitioning. You could document, patient attempted transfer from wheelchair to bed without locking brakes. Therapist provided moderate verbal and tactile cueing to facilitate brake check using verbal rehearsal strategy. Patient demonstrated improved safety awareness with 2 to 3 trials completed independently. That's not just worked on safety. That shows clear clinical reasoning, a strategy, cueing, and response. Here's another one. Your patient keeps missing steps in toileting. Instead of worked on sequencing, you could write patient completed toileting routine using laminated visual checklist with 5-step sequence. Therapist provided minimal verbal cueing for initiation and step progression. Patient required increased time to complete steps, but demonstrated improved task focus compared to prior session. Or maybe you're working on ambulation, but your patient consistently forgets to use their walker when getting up. You could document it like this. Patient attempted to stand from recliner without retrieving walker. Therapist implemented backward chaining strategy to reinforce safety sequence. Retrieve walker before rising. Patient required moderate visual and verbal cues to initiate sequence and demonstrated improved carryover with 2 out of 3 trials completed with walker in hand prior to standing. That's how we show cognition in the context of mobility. And yes, it absolutely counts as a cognitive intervention. Now let's talk cueing. One of the biggest documentation mistakes we see is just writing provided cues. That is not enough. You need to be specific. Was it a verbal cue to initiate a task? A tactile cue to maintain attention? A visual cue using a checklist, timer, or modeling? Did the patient need constant repetition or just a single reminder? The level and type of cueing you give directly shows your skill. So put that in your notes. And if you're thinking, okay, this is helpful, but I don't know what strategies to use or what counts as skilled, That's exactly why we created a cognitive section inside the Note Ninjas membership. We give you strategy banks, cueing language, documentation examples, and functional treatment ideas for every level of cognitive need. Because your treatment is already addressing cognition. You just need your documentation to reflect that. And here's one more tip before we wrap up. Always tie your cognitive intervention to a real-world functional task. Even if you're doing something abstract like sustained attention or memory, bring it back to something meaningful, like preparing a meal or navigating stairs or managing medications. So instead of worked on attention, you could write patient-completed 3-step grooming sequence with sustained attention during morning routine. Required moderate verbal cues to remain on task and complete all steps in order. The strategy we used was verbal redirection and use of neuro for visual anchoring. That's clear, defensible, and shows medical necessity. If you're tired of writing vague notes and want help documenting cognition in a way that actually sounds skilled, click the link in the description to learn more about the Note Ninjas membership. We'll save you hours every week while still writing notes that actually hold up. And don't forget to follow us at the Note Ninjas for more documentation strategies, functional treatment ideas, and time-saving tools that make your treatment sessions smoother and your notes stronger. You're already doing amazing clinical work. Let's make sure your notes reflect that.